Okay, thank you very much, Martin. So I can't feel any pressure on my shoulders at the moment. I'm repressing something. So thank you very much for the invitation. Thank you very much for organizing this. It was a wonderful conference, if I may say so. And I'm the last one, so people may have noticed that in some respects was similar. I always call Martin the better version of me. So this talk is actually by Martin Luyten and Patrick Debanet. As a team, all the time, people thought during the conference that I was doing my emails on my laptop, but I was actually doing the slides, trying to pull together, weave together some themes. And I thought about this song by John Baez. Some of you might know this. This is an age test, by the way. We both know what memories can bring. They bring diamonds and rust. So what are the diamonds in the mentalizing approach, and what is rust? What is something that perhaps we need to have another look at? You know, if your car has some rust, you go to the garage and you have it looked after. The mentalizing approach clearly coming of age, and I think that the mentalizing approach also needs some flexibility as well as resilience in the future. And in the three areas that we talked about during this conference, the theory, actually, and Toby talked a bit about the theory, the assessment, how we assess the concept of mentalizing or reflective functioning, as well as its clinical applications. And those are the three topics that I'm going to talk about and try to pull together and weave together some of the themes that we talked about over the last 2 days, so that you all can go home quietly, easily after this talk, and can have at least kind of the illusion that the conference had a coherent theme. Because this is the third MBT conference, so in terms of age, we're a bit above this level. So the MBT approach is actually somewhat in its infancy, if I may say so. And to introduce myself and my role here today, you all have heard about the Terminator, I'm sure. You've seen the movie. If you haven't so, watch the movie tonight. It's about mentalizing. It's a very sophisticated movie. So this is Arnold Schwarzenegger, and this is the integrator. This is me, thanks to Claire and the whole team at University College London. This is the integrator. Okay. However, all during the conference, I was a bit shaky, and I was feeling like this guy. This is me compared to all the others. Can you see this? I mean, it's shocking, but this is me, and all the time thinking, damn, I should have prepared myself better for this conference. So let's first start with theory. What have we done concerning theory? And I like this. This is one of the Peter Fonagy slides. I like this very much because it is a warning, and actually it's a very important warning. I think it's very important to believe in an approach and to be hopeful. And this is one of the features actually that explains the efficacy, the effects of all psychological interventions. So it's very important that we believe that we're on the right track. However, mentalizing theory, mentalizing approach is not a religion. It's not a kind of a new washing powder that washes whiter than every other kind of washing powder. You know, in the supermarket where you have all these kind of washing powder, and actually what's in it is washing powder, and it washes things. Yeah? So it's longer than all previous versions, and hurry up, there are only 2,000 copies left of the latest edition. So please buy our books. So I don't want to be a party crasher, but I think the third MBT conference about resilience and flexibility is also about looking back. Think about the memories thing, diamonds and rust. So what about, if you look at articles published about mentalizing, there's a steady increase, also particularly in the field of social neuroscience. And so we're doing well, we're right on track. And actually, this is PubMed publications on mentalizing, recent count, and this is on mindfulness. So we're beating the mindfulness people. So if you start to compare the size of our publications, we're doing better at the moment. But again, few of you understood that joke, it seems. Think a minute. Can you translate this properly? It might be inappropriate. So quickly moving on. This is a warning at the same time. It's not about competition at all, because if we look at conceptual overlap, has been alluded to on time and time again at this conference. There's a lot of conceptual overlap with conceptual cousins of mentalizing, like psychological mindedness, mindfulness, empathy, affect consciousness, and we tend to believe that they can organize in a kind of self-other pole and an implicit-explicit pole and so on. But these various fields and these conceptual cousins have very important contributions to make, and we should enter into a dialogue with all of these conceptual cousins, to be honest. And so there are many diamonds in the field of theoretical conceptualization of mentalizing, and we've seen some, and I'll return to some in a minute. But there might also be rust, because do we still know at this point what we mean by mentalizing? There's a kind of conceptual stretching of the concept going on. And so we need to be a bit careful that we don't overstretch the concept, because our colleagues would start to say, yeah, but everything is mentalizing. And you may believe this, but not everything is mentalizing. We've seen over and over during this conference that we need to take into account the dynamic nature of mentalizing. Mentalizing is not a trait. It's in part state-dependent, person-specific dependent, and context-specific dependent. You all know individuals who look like very good mentalizers until they start talking about their mom, for instance. Yeah? They lose all the marbles at that point. So we need to take that into account. Mentalizing is dynamic and is bidirectional. And what about the implication of the extension of the theory to include the theory about epistemic trust and salutogenesis, the capacity to benefit from a positive environment, which is crucially relevant to conceptualize our thinking or to understand our thinking about resilience, but has that been integrated enough in our theory? So there's a need for longitudinal studies as well. And what about the brain? As you may know, I'm quite fond of the brain. I like the brain a lot, and we've done several studies about it. And just what we saw actually at this conference is there's a lot of knowledge emerging about the brain and the different regions in the brain. But we've also seen during this conference that there's lots of plasticity in the brain, yeah? If I may say so. This is how people from the UK speak English, by the way. French, by the way. They think that they speak French if they do it like this. Yeah? Brain plasticity, very, very important concept. So let's not become followers of phrenology, but be very mindful about brain plasticity as well. Moving quickly on to assessment, it's very clear that the assessment, both for research purposes and clinical purposes of mentalizing, is also in its infancy. And fortunately, we have Ayas and Jerry Byrne, who left us already. I mean, this is what our friends do to us, Martin. Yeah. They just leave us. And many, many more within the mentalizing mafia that are thinking about creative ways to assess mentalizing, particularly taking into account the dynamic and bidirectionality of mentalizing in action. we should move into assessment of online mentalizing in the moment instead of offline mentalizing, which is also important, but the online and particularly the embodied mentalizing, what it means to be in the shoes of someone else. And for instance, let me briefly give you the example of the reflective functioning questionnaire that we recently developed. It seems to be a lot of demand for the questionnaire. We do have some evidence for the factor structure of the questionnaire, that it distinguishes between different kind of populations, that has nice correlations with BPD features and related features, that it predicts attachment security in the strange situation, that is mediated by parental reflective functioning, and I could go on and bore you to death with it. But the truth is that the reflective functioning questionnaire and the parental reflective functioning questionnaire are just screens, yeah? Not more. The simple screening tools for mentalizing. So we need to start thinking about much more elaborate measures of different facets or polarities of mentalizing. And we've seen some examples during this conference, and many more are underway, but this is where we need to move. Not making things more simple, but making things a bit more complex. Finally, and you see I'm a bit hurried, we've seen some diamonds, we've seen some rust with regard to theory, with regard to assessment of the concept of mentalizing. But I want to devote most of my time to the clinical applications of mentalizing theory, because I think this is the field that interests you most, and it interests me most as well. We've seen lots of diamonds over this conference, and this means actually that the mentalizing approach is coming of age. We've seen actually that the mentalizing approach, which originated in the study of BPD, borderline personality disorder, has now translated itself or developed actually a spectrum of interventions. With, at the bottom, prevention outreach programs. We've seen AMBIT, which is perhaps the best example of this, the resilience program, Capsule, the creating a peaceful schools and learning environment program, the Geneva Early Childhood Stress Project with Caveat, MBT parenting, which people at the Weersprong have developed in the Netherlands. We've seen Lighthouse MBT, Mining the Baby in the States, and so on and so forth. Beautiful programs. We've now got MBT spectrum treatments for symptom disorders like depression and anxiety. Dynamic interpersonal therapy is a good example of this. And for personality disorder, severe personality disorder, BPD, we heard Anthony Bateman speak about antisocial personality disorder. We've heard about extending the model to psychotic conditions, and almost at the very end of the conference, perhaps not coincidental, about ADHD and extending the model into the field of ADHD, which is very nice. We also heard Dawn speak about clinical staging, which is a very important approach that matches on this spectrum idea. And this relates very importantly back to this P factor idea, not the Peter Fonagy factor or the Patrick factor, but psychopathology or persistence factor, namely that at the base of this spectrum of conditions are these more gendered neurotic conditions. These individuals probably have relatively adequate adaptive levels of epistemic trust, so they're open to interventions. They're probably open to brief interventions, psychoeducation, even internet-based interventions, or they need just a little push from us to resume normal developmental trajectories. Then you have in the middle the more persistent conditions, partially gendered personality disorders, who lack epistemic trust, and in the extreme show epistemic petrification. They don't trust you. They enter into your office and they say, I'm not sure what I'm doing here. Yeah? Yeah? And so you may have lots of things to offer, MBT, yeah? But it doesn't seem to work. And finally, you have these psychotic conditions who have There are ungendered conditions probably, and lack any form of epistemic trust and have severe mentalizing problems and are very, very hard to reach. So where this leaves us with our model is actually a cause of concern. If you look at people trained, it's about, roughly speaking, 4,000 or 5,000 people. So you're actually among the lucky few if you're trained in the model, compared to the number of individuals that need us, that desperately need us. We're very few. We have the gold. No, not at all. Because if you look at Rust, I think, and I don't want to be a party crasher again, it's marvelous that we have developed this spectrum of interventions, but let's pause for a minute and also start asking the hard questions about our own approach. We recently published a number of papers with a group of people, and just taking out a few of the points that we touched upon in these papers is there publication bias in the field of psychotherapy? Yes. Is there publication bias in the field of MBT? Perhaps. We're at an early stage, so we need to be very careful also to publish negative findings, yeah? Not so welcoming findings. Very, very important that we do that. We have to learn from our approach, and we need to be true to our own standards. We have to live up to our own standards. Small N studies. Lots of studies have small sample sizes in psychotherapy research and in the MBT world as well. So what we need is actually not only more studies, but larger N studies that are more powered towards finding significant results. And perhaps we have fallen prey to overemphasizing small differences with other treatments. Perhaps. And so we shouldn't kind of gloat in the kind of glory of we're doing better than other treatments. That's a very, very dangerous kind of attitude. Because some of us can look around the bend, and what we see coming actually are studies that fail to show that MBT is any better than other approaches. And this is actually what we truly believe in. That there's lots of routes towards effective treatments. We may, and I'll give you a few examples in a minute. We may be ignoring therapist effects as well, very important. And the last emerging field that we're very interested in currently is treatment integrity and implementation of MBT in routine clinical practice. Let me try to give you a couple of examples. This is what's happening in the field of cognitive behavioral therapy for depression and other conditions. If you plot the effect sizes across time, this is what you see. Meaning in the 1980s, CBT had kind of large effect sizes, particularly compared to control conditions, equal to control. Yeah? And across time, the effect sizes of CBT in trials has gone down. Yeah? To the point that there's almost no difference no more between CBT and control conditions. There are many reasons for this. One is that control conditions have become more effective. We have learned. And the second is that something has happened to CBT, that some of the effective ingredients of CBT have been lost along the way, perhaps. And we need to be very careful that we don't do the same with MBT. I think that MBT is a lot about a playful attitude, a creative attitude towards minds, towards people. And that we shouldn't expect this model to translate perfectly into a neat manual. Yeah? And we shouldn't expect that every clinician will be able to do effective MBT, actually. And you can say, okay, this is adolescence. Well, the CBT people had to take a second blow very recently, so we should feel for them. And I feel for them, because this might be what's going to happen to us as well. So it's a very selfish kind of empathy. Anthony Bateman might have some ideas about me based on that. But so this is the effect size of CBT in general across time. It's also decreasing, yeah, for adults, not only for adolescents, but adults as well. And for instance, if you look at the field of borderline personality disorder treatment, time may be against our side, because if you look at the most recent clinical trials comparing a specialized treatment for BPD, like MBT or DBT or schema-focused therapy versus a control condition, most of the trials show that there's very little difference between the specialized intervention and the control condition. And believe me, there are a few papers on the way showing that as well for MBT. Yeah? And this is, for instance, the reason why we see more integrative treatment protocols emerging for BPD, amongst them one by Anthony Bateman and a colleague from Australia. That integrative treatments that actually focus on the most likely effective ingredients across treatment approaches. Yeah? So again, it goes against the idea that MBT alone is the gold and all the rest is the copper in terms of treatment. So is that all there is? Common factors or placebo? They should worry us slightly. And very importantly, one of the key features actually of MBT is that it was very attentive from the beginning to possible damaging factors of treatment, iatrogenic factors. It tried to avoid doing harm to individuals. This is actually one of the starting points of MBT for borderline personality disorder. Do not harm. Do not do harmful things with these patients, like overstimulating the attachment system. And this is called in literature nocebo effects, so the opposite of placebo. And there's a very nice study demonstrating that. This is the cortisol response before you get an injection. When you get an injection, 10, 20 seconds, 5 minutes after, and so on. And you can get this injection by someone in a white coat, a medical doctor, supposed medical doctor, who is very kind of positive towards you, very validating. He's very warm and gentle, and he says, it might sting a bit, but just slightly, and you won't feel, this won't hurt a bit, and you'll be fine. Stress response, almost non-existent. Yeah? Versus when you get this injection from a medical doctor who gives you some ambiguous feedback, kind of not sure whether this is going to hurt or not. It might actually hurt, and then you see kind of a very high stress response. See the point? So it's very important that we believe in the model, but also that we take the model serious and try to avoid iatrogenic interventions. And so I promised to tell you something about implementation and treatment integrity, and I stole these slides very helpfully from Dawn Bales. She gave them to me, to be honest. This is actually a study that is on the way. We're about to publish, hopefully, Dawn, very soon, is showing the effect of MBT, mentalization-based treatment for borderline personality disorder, before a reorganization of the treatment unit. And we heard about reorganization and reorganization and reorganization happening all the time. And you see that MBT was associated with very nice effect sizes across 1.5 and even 3 years, very nice, moderate to medium to large effect sizes. If we see then that this treatment unit was, this is the one, sorry, this is the one. You see it nicely decreasing with very nice effect size. If we see it that during the reorganization of the treatment unit, you see that effect sizes actually are much, much lower. And this is the global symptom index. And you see that after 1.5 years, the effect size was about half of the original effect size. At 3 years, it was about 1/3 of the effect size. So this is a clear warning. Don't implement MBT when you don't have the means and the context to implement it properly. This is where, for instance, the MBT quality manual comes in. But what we're going to see most likely in the coming years is that a bit of the Wild West situation where people are going to implement MBT in less than optimal conditions. And we'll see the effect sizes dropping, like we see for CBT. Yeah? And then the CBT people will laugh at us. Yeah? See? So be very careful next time you laugh with your CBT colleagues. I've grown up in the Catholic tradition, you can tell. I'm a bit masochistic. You can tell, okay, but these are symptoms. But if you look at more personality features like identity integration, relational capacities, responsibility, social concordance, social self-control, you see very similar findings. Yeah? So very important implementation and treatment integrity. I'm going to skip these. Also, we need to start asking ourselves, what kind of treatment is MBT best suited for? And there are some indications that MBT might be particularly effective for the most severely disturbed patients. Like this paper of Anthony Bateman, Peter Fonagy showed that with one axis 2 diagnosis, MBT and structured clinical management are equally effective. With 2 axis 2 diagnosis, you start to see the difference. With 3, even more, and with 4, it's very clear. Yeah? So it might be particularly suited for the most severe patients. At the moment, there are some indications, but we're not sure. These are just first indications that need to be replicated. Okay. Let me end with, almost end with something about, we need to say something about epistemic trust, because this was a theme that emerged in the conference as well. And just to illustrate you again the concept of epistemic trust, we're in Geneva, in Switzerland. They eat these things that grow in the woods. Yeah? And the question is, whom would you trust if you go picking mushrooms in the forest in Switzerland? Yeah? Would you trust this guy? Kind of, probably not. This guy, for the UK people, this girl, you might trust her for other things, but not mushrooms, perhaps. These guys, and would you trust them? Or this guy with his dog? Yeah? This is what epistemic trust is about. This is how patients actually enter our treatment room, with large differences in the capacity for epistemic trust. Yeah? And this is a very important addition to the mentalizing model. This is another illustration of it, which I'm very familiar with. Okay. But where does it leave us? I'm almost coming to the close here, to the end. Where does it leave us, actually? It leaves us with a very prominent role for MBT, for mentalizing, but perhaps not the only one, again. It suggests that there's a 3-pronged approach to explaining the efficacy of all psychosocial interventions, including MBT, but also other interventions, by 3 systems of learning. You may be familiar with this, but for those of you who are not familiar with this, the first system is a specific therapy or intervention that you're offering. And this system, it can be effective to the extent, in our opinion, that it mirrors something back of the subjective experience of the patient, whether that's by promoting or offering a theory about you're characterized by dysfunctional attitudes or lack of mindfulness or mentalizing, doesn't matter. As long as the patient feels mirrored by the clinician, understood and validated by the clinician, that may restore the capacity in the patient or develop the capacity of epistemic trust and its closely linked ally of mentalizing. So this means that there are many, many interventions that may actually explain in part or be effective in part in this first system. The common factor is the second system of learning, that all effective treatments, because they mirror the patient's subjective experience, and the patients feel mirrored and validated, they start opening up towards the clinician, towards the theory, and they start mentalizing in a different way about themselves, which subsequently opens them up to this social learning process or salutogenesis, this capacity to learn and to benefit from the outside environment. And the implications of this model hasn't been well thought through yet within the mentalizing approach, because, and we saw several hints of this. We saw, for instance, that we're moving away to this traditional model of the patient and the therapist in a room to a model that is more outreaching and that includes the system of the patient. And this has dramatic consequences, because we may be able to change parts of the subjective experience of the patient, but perhaps not always parts of the social system or the context of the patient. So we need to start moving into the environment. And this may mean that patients often have to change their environment themselves, helped by clinicians. But also this means that the therapist itself also needs a support system. And this has often been forgotten and leads us back to the issue of treatment integrity and implementation problems. We need to support the ones who support. We need to scaffold the ones who scaffold. And this is a very important message to take home to managers, for instance, of treatment units, because they need to invest in supervision and intervision and training. Because you can't treat people without being supported yourself. This is a complete misunderstanding of traditional clinical practice. Okay, I'm going to skip this. Okay, so what I've tried to do is weave together, very incomplete, I believe, but trying to weave together some of the themes concerning the theory, the assessment, and and the clinical applications of mentalizing theory. And I believe that we need flexibility and resilience in the coming years. And I'd like to end this conference with two calls for the field. First, that we continue to develop a critical but realistic and at the same time hopeful attitude towards the mentalizing approach. We are special. Okay? But perhaps not as special as we think we are. And finally, this is an open call to join forces, you as a clinician, you as a researcher, to join forces in developing broader and more high-quality research programs in each of the areas mentioned. This is what we need for the future. We need to build from strength to strength. And we need to do it quite urgently. This is like the kind of sell-by date on many products. And I believe we need to produce better evidence in the future. And let me end by two quotes. Albert Einstein, logic will get you from A to B, imagination will take you everywhere. And I think we've seen some of that in the poster sessions, didn't we? People doing completely new things, which is very hopeful. And finally, this is your comfort zone. Yeah? And this is where the magic happens. So this is an open invitation to enter into the circle of where the magic happens. Thank you very much.
Fantastic talk, Patrick. Thank you. We have time for maybe 2 questions.
Where is the airport? I can give you directions on the screen if you... There's a question.
Thanks for the very interesting talk. And I just wondered if you wanted to expand a little bit on the notion you touched in terms of getting outside feedback. How is MBT going to be influenced? And I don't know if you're familiar with, probably are, with Scott Miller's feedback-informed treatment and that sort of thing. I don't know how, if you've had any thoughts about feedback and how it relates to MBT's development.
Yeah, you're talking about routine outcome monitoring as well?
Yeah, I'm not specifically,
Yeah,
but
okay.
I'm coming from that sort of point of view.
Okay, feedback matches the mentalizing approach perfectly. We have to carefully consider when it's appropriate and when not. But for instance, in dynamic interpersonal therapy, it's built in to the model, even with routine monitoring. The start of each session, there are two very brief questionnaires, the patient health questionnaire 9 and the general anxiety questionnaires 7, 6 items. The patient has to complete that, and we look at it and so on. So it's built into the model. So I believe there's a very important case to make to include that in as much as possible, when appropriate, into the MBT models. Because the essence of the MBT model is I have nothing behind my back. I'm very open about my thoughts, my feelings. I use my own mind. And so I'm also very open to feedback. So misunderstanding is actually crucial. And this is what we learned from all this research, is that clinicians, not you, but all the other clinicians, the one who have left now, they have no clue whether a patient is doing well or not in treatment, or is thinking about ending the treatment, dropping out, for instance. It's a chance finding. 50% of the time you're correct, 50% you're wrong. So this is what this research has taught us, is that we often don't have a clue how the patient is doing in the treatment. So it fits the MBT approach very, very well, that the patient can offer us feedback. And for instance, in London, we have developed the POD system, patient-owned device, it's called, and the patient can log into that system and look at very nicely done trajectories of symptoms, for instance, or any measure that you want to put into in that system to look at how he or she is making progress and no progress, and so on and so forth. So we provide the patient actually ownership of the whole feedback system. Not a clinician, not a researcher, but the patient. Does that answer your question a bit?
Yeah, fantastic, thanks.
And it's for sale, by the way.